Welcome everyone to the joint Immunize Canada and CANVax's webinar. Immunize Canada is collaborating with the CANVax project to host a 4-part webinar series on the topic Immunizations during the SARS-CoV-2 pandemic. The objectives of this webinar series are to understand the importance of maintaining recommended immunizations throughout the life course during the pandemic, to identify best practices and strategies for safely coordinating and delivering immunization programs during a pandemic, and to describe the impact of immunizations during a pandemic. To learn more about our upcoming webinars, please visit our website at CANVax.ca under Webinar Series, where you will find the Joint Immunize Canada webinar page. And this is also indicated on the link you see on the screen. Before we begin, we want to acknowledge that the Canadian Public Health Association, CPHA's office is situated on the ancestral and unceded territory of the Algonquin and Anishinaabe people. They have been the guardians of this land for millennia, and we are grateful for the example their stewardship provides. Immunize Canada and CPHA are committed to working with all First Nations, Inuit, and Métis peoples and their government in realizing meaningful truth and reconciliation. Today's webinar, Maintaining Immunizations During COVID-19 Pandemic, Why and How, is brought to you by Immunize Canada and is hosted by the CANVax project. This webinar series has been made possible from an unrestricted educational grant from Merck and Pfizer Canada. Immunize Canada appreciates the financial support it receives from its sponsor members. All financial support, including educational grants, is used to cover the development of educational materials and campaigns. Immunize Canada retains editorial control over all aspects of these materials. Please visit immunize.ca for Immunize Canada's ethical guidelines for sponsorship. For today, I'm Ritian Xu, Project Officer with CPHA, and I'll be the moderator for this webinar. Helping me out is my colleague Antonella Pucci, also a Project Officer on CANVax. As for a bit of housekeeping, all attendees are muted. However, the toolbar located at the bottom of your screen offers a few interactive features. For this webinar, the Q&A feature will be used to ask questions. To ask a question, please type them in the Q&A box. You can do so at any point during the webinar. Only you, myself, and the presenter can see your questions in the My Questions section. And you, as the attendee, have the option to submit them anonymously. When a question is asked to the presenter, the question is first read out and then will be answered live by the presenter and then posted in the All Questions section for everyone to see. Feel free to submit your questions at any point during the presentation using the Q&A feature. All questions will be answered at the end of the presentation. If you are experiencing technical difficulties, please also ask them in the Q&A box and we will reply to you. If multiple people are experiencing the same problem, we'll address it live. We strongly encourage attendees to ask questions throughout the presentation, and we look forward to hearing your thoughts and questions. A couple quick notes before we start. This webinar is being recorded, and the recording will be made available on Immunize Canada's YouTube channel and on CANVax's Joint Immunize Canada webinar page after the end of this presentation. Please note that after the end of this webinar, you will be invited to take a short 5-minute survey on today's presentation. We strongly encourage you to take this survey to provide your feedback so that we can assess your satisfaction and identify areas for improvement in the delivery of this webinar series. We take all suggestions into consideration and we appreciate the time you take to fill out the survey. So with that, I would like to introduce our speaker for today's webinar, Dr. Angel Chu. Dr. Chu holds a BSc Honors in Pharmacology and an MD with special training in research from the University of Alberta. She completed an internal medicine residency followed by an infectious disease fellowship at the University of Calgary. Additionally, she completed an infectious disease subspecialty training at St. Paul's Hospital in Vancouver, BC. Currently, Dr. Chu is the clinical assistant professor and infectious disease specialist at the University of Calgary, the medical director of the STI clinic in Calgary, and the vice chair of Immunize Canada. Her special interest is in adult immunizations. And with that, I would like to turn it over to Dr. Chu.
Thank you very much for that very kind introduction. And thank you very much to Immunize Canada and to CANVax and to all the sponsors for hosting this afternoon's presentation. And also I'd like to thank the attendees for taking the time to attend this presentation, where we will be learning about how to maintain immunizations during the COVID-19 pandemic, the why and the how. So as part of my disclosure information, I have received research support in the past from Calgary Lab Services, and I've also received honoraria and consulting fees from Merck, Pfizer, Sanofi Pasteur, GSK, and Avir Pharma as well. I have had full editorial control over the content of this presentation, and everything that I'm presenting will be referenced according to our NACI immunization Canadian guidelines. So as part of the program overview for this afternoon's presentation, we will be discussing the global successes of immunization programs in prevention of infectious diseases. We'll also explore some strategies for how to safely coordinate and deliver vaccines during the COVID-19 pandemic. And ultimately, we'll be able to understand the importance of continuing immunizations during the pandemic. So just a few questions to start the presentation with, and you can just think of these answers to yourself. But what is Canada's vaccination coverage goal by 2025 for all childhood vaccines? Is it A, 75%, B, 80%, C, 85%, D, 90%, E, 95%, or F, 100%? And the answer is E, 95%. So Canada has established a set of goals for vaccine uptake coverage rates, and it's based on, and the number is 95%. And that number is based on the estimated uptake that is required to prevent measles, because measles is considered one of the most highly contagious and highly infectious vaccine preventable diseases. And in order to sustain zero transmission of measles within Canada, we need to have vaccine uptake rates of 95%. The second question is, Canada is on track to achieve vaccine-preventable disease, or VPD, reduction targets by 2025 for all notifiable infections except, is it A, tetanus, B, pertussis, C, measles, D, mumps, E, invasive pneumococcal disease in adults over the age of 65, or F, both E and F? And the answer is F. So currently Canada is on track to achieve all of our targets except for both measles and invasive pneumococcal disease, or sorry, for mumps and invasive pneumococcal disease. Mumps, there were some isolated outbreaks back in 2016 and 2017, and there is great concern that with reduced vaccination uptake rates that there will be ongoing mumps transmission. And invasive pneumococcal disease in adults, unfortunately, the vaccine uptake rates are still very, very low. Our targets for invasive pneumococcal disease vaccination rates in adults over 65 is currently 80%. Unfortunately, our current rates of uptake are only sitting at about 42%. And with such low vaccination uptake numbers, we're nowhere near being on track for the reduction targets by 2025. So we have a lot of work to do for invasive pneumococcal disease. And the last question is, true or false? Childhood immunization rates have decreased by up to 20% in Canada during the pandemic lockdown from March to April of 2020. And that answer is true. So Manitoba is one of the provinces who shared their immunization rates, and they were able to have good data and tracking of immunization coverage rates. And they estimated that there was about a 20% decrease in all of their childhood immunization rates for children less than the age of 2, just in the 2 months of the pandemic lockdown. So of course, that is of serious and grave concern, because any interruptions or disruptions in immunization programs, even for short periods of time, can lead to an increased number or an increased susceptible population that will be susceptible to these vaccine preventable diseases. So I don't think I need to impress upon this audience how important immunizations truly are and what a truly global success story immunizations really are. So immunization programs are hailed as one of the greatest achievements in medicine, and it's improved the lives of more Canadians over the last 50 years than any other health intervention. And the success of childhood immunization programs have led to record or near record lows of vaccine preventable diseases. And even as I was preparing for this presentation, just reading some of the historical data, even as recently as the early 1900s, so 100 years ago, there were hundreds of thousands of deaths in children from vaccine preventable diseases. With the advent and successes of our immunization programs, we have reduced those numbers by 99%, or in some cases even eradicated diseases. So much so that on an annual basis, it's estimated that we're only seeing about 7,500 vaccine preventable disease deaths on an annual basis in the last few years. So to me, that is a huge success story, huge reduction in disease, but still hearing about those 7,500 deaths is still far too many, because in my opinion, with the highly effective vaccines and the programs that we have currently, we should be seeing zero childhood deaths from vaccine preventable diseases. So we know, of course, that vaccines work, and this is from the Public Health Agency of Canada, where they've estimated cases of vaccine preventable diseases and defined them as then, which is the 5 years before a vaccine was available, and then now, which is the 5 years after a vaccine became available. And you can see for things like whooping cough or pertussis, we've seen a 93% decrease since the pertussis vaccine was introduced. For measles and chickenpox, we've seen a 99% decline in disease and incidence since those vaccines were introduced. Mumps, we've also seen a 99% decrease, and we were doing a great job in reducing mumps transmissions until the recent outbreaks in 2016 and 2017. Diphtheria and polio, we've had 100% elimination, and we've reduced those rates quite dramatically in the time since vaccines were introduced. So the Public Health Agency of Canada came out with a surveillance report at the end of December of 2017. And this report looked at the 5-year time span from 2013 to 2017. And it basically summarized the epidemiology of 12 nationally notifiable vaccine preventative diseases for which there are publicly funded programs for vaccines in every province and every territory. And they looked at a surveillance of the incidence and the number of cases, and also of vaccine uptake rates during the 5 years from 2013 to 2017. Along with that, they also did a survey of patients and parents' acceptance and attitudes towards immunizations. What was really encouraging about this report is that Canada is doing a fantastic job overall in maintaining high levels of coverage rates and reduction of vaccine preventable diseases. So currently, as of this report, vaccine preventable diseases that were under elimination included measles, for which we eliminated in 1998. So we've had 0 cases of endemic transmission of measles since 1998. There have been, of course, imported cases from other countries, but in Canada, there have been 0 endemic transmission. Rubella, which we eliminated in 2005, including congenital rubella infection and syndromes, which was achieved in 2000. And of course, polio, which Canada eliminated in 1994. So it's great. We've continued on with the elimination of these diseases. We've done a fantastic job. There are certain infections, unfortunately, that still have a low level incidence. And these include diphtheria and tetanus, where we do tend to still see less than 5 cases per year. Haemophilus influenza type B, or Hib, where we're still seeing about less than 25 cases per year. Invasive meningococcal disease, where there have been less than 200 cases per year. Of course, we now have meningococcal C vaccinations, which are offered to children less than the age of 2 in all provinces and territories. And that's why we've dramatically reduced our serogroup C incidence. But still 9% of those 200 cases are all caused by serogroup C. Whereas now the predominant strain causing invasive meningococcal disease in Canada is serogroup B at 41%. And that is because even though there are vaccines currently available for serogroup B meningococcal disease reduction and prevention, no province or territory currently publicly funds it. Mumps, we talked about where there were the outbreaks in 2016 and 2017 in predominantly adolescents and adults. And the concern is that with low mumps vaccine uptake rates, that there will continue to be ongoing outbreaks. And so this is being closely monitored. And then, of course, there are still, unfortunately, vaccine-preventable diseases that still have moderate level incidence. And these diseases include pertussis, which unfortunately we've been noticing an increasing trend with the highest incidence in infants less than the age of 1 year. And we tend to often see pertussis outbreaks on a cyclical cycle between every 2 to 5 years. And infants less than the age of 1 are the ones that have the highest mortality rates if they are infected with this infection early on in life. Invasive pneumococcal disease, unfortunately, still has moderate level incidence, and the highest incidence is in adults 60 plus because of the low immunization rates, and also because this is the most susceptible population with the most number of risk factors. And the second highest incidence is found in children less than the age of 4. And that is quite disappointing to see because we have PCV13 vaccines, which are included in the childhood immunization programs, which are highly effective. But unfortunately, again, because we're seeing low uptake rates or missed doses, we're seeing an increasing incidence of invasive pneumococcal disease in children less than the age of 4. And then varicella, despite having highly effective vaccines, is still a disease that carries moderate level incidence. So for all of these infections, Canada is currently on target to reach our 2025 goal for VPD reduction in disease, except for mumps and invasive pneumococcal disease. So we still have a lot of work to go if we want to make any kind of improvement in disease incidence with mumps and invasive pneumococcal disease. So as part of this surveillance report as well, there was a national immunization coverage study looking at childhood immunizations and children and the percentage of children who received their immunizations prior to their 2nd birthday. And you can see here that the line at the top is the national coverage goal, where we hope that for all children by the age of 2, we would want vaccine uptake rates to be at least 95%. And that again is based on the measles transmission and the expected level of immunization of the population in order to sustain measles protection and herd protection within our country. So 95% is the goal. And you can see that for certain vaccines like polio, measles, mumps, rubella, and meningococcal C vaccines, that we're doing a fairly good job where vaccine uptake rates are fairly high, not quite at our target of 95%, but in the 90 plus percentiles. What was disappointing about this study is looking at the time periods from 2013 to 2015 to 2017. And you can see that pretty much all of these bars has stayed flat. So we haven't improved our immunization coverage rates despite going from 2013 all the way up to 2017. So again, we need to do a better job at that point with increasing coverage rates. But also looking at certain other vaccines, such as diphtheria, pertussis, tetanus, and Haemophilus influenza B. These vaccine uptake rates are extremely low and nowhere near the threshold of 95% goal that we would want to attain. And the concern is that with such low vaccine uptake rates, that there's going to be a resurgence of disease, especially with partially immunized or incompletely immunized children. We're lucky in Canada that we have currently very little endemic disease of pertussis and tetanus and diphtheria and Haemophilus influenza, that we don't see a high incidence of disease despite our low vaccine uptake rates. But with continued interruption or continued abstaining or hesitancy of vaccines and continued low coverage rates, it is of serious and real concern that we can see a resurgence of disease. So we certainly have done a great job in our immunization programs, but there is certainly still a lot of work that needs to be done. Looking at the total number of vaccine-preventable disease cases in Canada, overall from 2013 to 2017, there were 37,000 vaccine-preventable diseases that were seen. Children less than the age of 1 had the highest incidence rate at about 9,200 per 100,000, and adults over the age of 60 had the overall highest number of cases. So right off the bat, you can see that the adult population is where we need to focus on, because we know that adult immunization rates are at an all-time low, and that's reflected in the number of disease cases that we see in adults over 60. But then the other concerning feature is in our children less than the age of 1. So this is the highly susceptible and highly vulnerable population, where if children get these vaccine preventable disease infections, then they're the most likely to suffer the worst outcomes and potentially die from infections. So things like pneumonia, sepsis, abscesses, meningitis, they're all going to be at high risk of getting these fatal diseases if we don't do a better job at increasing our immunization rates. Measles in Canada is really one of the great success stories. And you can see that from the 1950s all the way up into the early 2010, you can see that before we had vaccines available, measles incidence was very, very high. And measles in particular is one of the most highly contagious and highly infectious infections. So measles is one of 5 truly airborne infections where it's spread through the air, and those in close proximity to somebody who has active measles, there's about a 90% secondary attack rate. So measles is very, very highly contagious, and that's why prior to the vaccination era, we saw high numbers of cases. And unfortunately, measles has a high fatality rate as well, whereas in children who get measles, there's a high incidence of encephalitis and a high mortality rate as well. Thankfully, though, in the 1960s, measles vaccines were introduced, and in 1983, a routine 1-dose MMR vaccine was introduced. And you can see that in that time span, we saw dramatic reductions in our measles incidences. Unfortunately, there were some spikes that were seen towards the latter part of the 1980s and the 1990s, and that's when they discovered that a 1-dose MMR vaccine was good. It offered about a 75% protection, but a 2-dose vaccine offered close to 99% protection. And in 1996 is when we moved to a 2-dose MMR vaccination schedule. And since then, since 1998, we've actually eliminated endemic measles in Canada to the point where we've had 0 active cases since 1998. You can see here in 2011, 2012, and all the way up to 2015, there have been some cases of measles in Canada, but these were all imported cases from other countries. And as long as measles is not eradicated or eliminated in other countries, it poses a threat to Canadians because somebody can always bring it into our borders. And if we have an unvaccinated or susceptible population within Canada, then we can see measles become endemic in Canada very, very easily once again. And of course, we know that even though we're lucky in Canada to have eliminated measles, worldwide, we're nowhere near elimination. And in fact, measles continues to increase worldwide. And you can see some of the hot spots around the world where Brazil, Congo, the Philippines, Nigeria, a lot of African countries, they tend to have tens of thousands of measles cases with high incidence rates. And so there's measles that's still ongoing in much of the world. And so we're always on our toes and we're always worried that some of these cases will make their way into Canada. And of course, the concern is that with the global pandemic with COVID-19, that there have been so much interruption and disruption or suspension of immunization programs in a lot of these countries around the world, that it will make the measles incidence and the measles cases even more profound and even worse than the situation that we're currently seeing. So of course, the world has been in an unprecedented situation with the lockdowns, and every aspect of our lives has been affected by this COVID-19 pandemic. COVID-19, of course, is caused by the SARS-CoV-2 virus. It's one of 7 new novel coronaviruses that have been discovered. And you can see that this is the Public Health Agency of Canada's estimate and trends of what's going on globally with COVID-19. So we know that a lot of the countries who've made it past the first wave were starting to, of course, open up from the lockdowns and open up in phases. Some countries, such as the United States, have had to revert back to some of the more stricter lockdowns because of a resurgence in COVID cases after they've opened up. But Canada, you can see, has been on the downtrend, and some of the early European countries that were hard hit, such as Italy and Germany, they're also on the downtrend in terms of COVID-19 cases. The hotspots in the world right now are the United States, which we tend to hear about daily, how they're breaking record numbers of cases of COVID that they're seeing in the US. Brazil is, I believe, number 2 in the world now, followed by India and Mexico. But those are the hotspots. And of course, every country around the world is in different phases of opening up. But of course, COVID-19 has disrupted and interrupted every aspect of our life. Worldwide, it's estimated that as of this morning, there's over 13.3 million cases of it and over 579,000 deaths. And unfortunately, with the ongoing transmission and cases that are still occurring in the US, Brazil, Mexico, and India, that it doesn't seem like COVID is going to go away anytime soon. So we have to adapt to a new normal. Looking at what COVID-19 has done in Canada as of July 13th, 2020, you can see the age distributions where we're seeing COVID infections. So all age groups have been affected, all the way from children all the way up to, of course, the elderly. Whereas the bulk of the infections have occurred between adults 20 to 59 years of age, where about 14 to 15% of all of these, of the decades in between, have had COVID infections. So certainly there's no age group that's immune to COVID, and we're seeing infections across all age groups. But when you look at the serious outcomes, and those are defined as hospitalizations, ICU admissions, and deaths, you can start to see a skew in the bars where with ICU admissions, it's predominantly older adults who end up in ICU. So when we look at the majority of ICU admissions, it has been occurring in adults 60 to 69, with the next highest population being the 70 to 79-year-old. So we know that older adults are particularly going to succumb to serious outcomes, including ICU admissions. In contrast, that with children less than the age of 19, even though overall they account for about 7.38% of all total cases, only about 23 or 1.1% of children less than the age of 19 end up in ICU admissions. And then going forward, looking at deaths, where we can see that it's even skewed more towards the older adults and towards our seniors now, where 71.7% of all the total deaths from COVID that we're seeing in Canada occur in the 80+ category. And in fact, when we look at all the deaths that have occurred in Canada, 97% of all the deaths have occurred in adults over the age of 60. So we know that serious outcomes and deaths are disproportionately affecting our older adults and seniors. And of course, in the 80+ category, this is where we're seeing all the outbreaks in long-term care facilities that account for this dramatic shift and this big burden in adults 80+. So a couple of takeaway points from the age distribution and the serious outcomes and deaths from what's going on with COVID in Canada, where first and foremost, we know that children less than the age of 19, we've only seen 1 death in Canada as a result of that. And we know that children less than the age of 19 tend not to have serious negative outcomes from COVID. So when it comes to childhood immunization rates, we can assure our parents that it's still okay to bring your child out to go and get their routine immunizations, because the risk of children getting a serious harmful outcome from COVID is essentially negligible, whereas their risk of getting an infection with a vaccine-preventable uh, infection and getting a negative outcome and getting a complication from that, including things like meningitis and pneumonia, are far more serious and far more likely if they miss their vaccines. So we have to kind of shift our way of discussion and reassure the parents more that there are far more serious threats to children that are not COVID related. And the other takeaway is that our adult population, in particular 60 plus, that age group is particularly vulnerable to COVID. And so we need to do a better job at protecting our adults and protecting our seniors. And that includes optimizing all of their immunizations. So while the world, of course, is still reeling from the effects of COVID, let's not forget that there are other communicable and non-communicable diseases that are still killing tens of millions of individuals worldwide. And these diseases do not care if COVID exists or not. So the top 10 global causes of death in 2016, as estimated by the WHO, and the #1 cause of death is ischemic heart disease, followed by stroke. And the third biggest killer of people worldwide is COPD, or chronic obstructive pulmonary disease. But the fourth most common cause of death is actually lower respiratory tract infections. And that, of course, includes pneumonia. And then rounding out the top 10, you can see that diarrheal diseases and tuberculosis are number 9 and 10 on that list. So within the top 10 global causes of death, we have 3 major categories of infectious diseases. So we know that infections are bad worldwide, regardless of whether or not there's COVID. And now we have the added complexity of COVID. Looking at Canada and the leading causes of death in Canada, Statistics Canada estimates that the #1 cause of death in Canada are cancers, where it kills about 79,000 Canadians on an annual basis, followed by heart disease and strokes. But looking within Canada, influenza and pneumonia is the 8th most common cause of death in Canada. And together, influenza and pneumonia are the most lethal infectious diseases currently. And so with this upcoming respiratory season, which usually starts to hit around October to the end of February or March in the Northern Hemisphere, we need to be more vigilant and especially protecting our elderly, vulnerable population with our influenza and pneumococcal vaccines. And so with the lockdowns and restrictions and cancellation of medical services, we know that our childhood vaccination rates have dropped down. And so with that, there's real serious concern that there is going to be outbreaks of other infectious diseases. And especially as we go through phases of reopening, there's a real concern that vaccine-preventable diseases could surge. And this is even before our Canadian borders open up to international travelers. So once our borders start to open up and then there's an influx or efflux of people coming in from other countries where their vaccination programs could be more severely impacted, then we may potentially see more of a surge of these vaccine preventable diseases. And we know that that's dangerous because vaccine preventable diseases can quickly reappear if immunization rates decrease. In Japan, there were 2 infant deaths after getting pertussis vaccines, and later on they were found, of course, not to be associated from the vaccine itself. But as a result of those 2 cases, they experienced a decrease in immunization rates from 90% to 40%. And as a result of that, the cases of pertussis in Japan went from about 200 to 400 per year to 13,000 over 3 years, with over 100 deaths of infants. So very tragic that even a short interruption or drop in immunization rates can have that kind of profound effect. In Ireland, the measles immunization rates declined to about 76% as a result of the false and inaccurate and later retracted association of measles vaccines with autism. And unfortunately in 2000, measles cases then increased from 148 to 1,200 with several childhood deaths. And in the Commonwealth of Independent States, or the former Soviet Union, as they were going through the transition from the Soviet Union to the Commonwealth, vaccine in that politically chaotic time, vaccine uptake rates decreased and diphtheria reemerged with over 140,000 cases and 4,000 deaths. And most recently, with the COVID pandemic, we know that it has seriously and dramatically affected our polio rates. So polio was almost eradicated, but then coronavirus came, and then of course a threat from the United States President, Donald Trump. So we know that there are still endemic polio cases that is still actively being transmitted, and the hotspots are Afghanistan and Pakistan. Nigeria recently achieved polio elimination status after not having a wild case since in the last few years. So the active regions currently in the world are Afghanistan and Pakistan, unfortunately. And there's still some ongoing cases in other parts of the world as well. But with these third world countries or resource poor settings, they rely on an oral polio vaccine, and they rely on healthcare workers and volunteers and various agencies such as the United Nations and UNICEF and the WHO to go around, and they have door-to-door campaigns where they try to reach mass hundreds of thousands of children to inoculate them and immunize them. But unfortunately, with the lockdowns, with coronavirus and travel restrictions or reallocation or shifting of healthcare workers' job responsibilities, there have been suspensions or interruptions in the poliovirus immunization programs. And as a result of that, you can see how it's affected the polio cases. So year to date from 2019 to 2020, we've already seen a large spike in wild polio cases from 64 to 85, and also from the circulating vaccine-derived poliovirus cases, where it's gone from 69 cases in 2019 all the way up to 210 cases year to date already in 2020. And with the suspensions and interruptions in oral polio vaccine programs, these numbers could skyrocket very, very quickly. So we know that not only has the pandemic negatively impacted our vaccine uptake rates, but COVID-19 has also significantly impacted health services for non-communicable diseases. So the World Health Organization estimates that about 41 million people die annually from non-communicable diseases, and that accounts for about 71% of deaths worldwide. They did a survey of 155 countries during the pandemic, all countries around the world, from low income to middle income to high income countries, where 53% overall reported a complete or partial disruption of hypertension treatment, 49% reported disruptions in diabetes or diabetic complication treatment, 42% reductions in or interruptions in cancer treatment, 31% in cardiovascular emergencies, 50% were impacted with reductions in public screening programs, for example, cancer screening programs, and 63% reported disruptions in rehab services. So all aspects of health and healthcare are being negatively impacted because of COVID. And as a result of that, we're seeing excess deaths. This article was just published in the JAMA Network a couple of weeks ago, looking at the overall death rates on an annual basis in the US. And they compared the period from the first few months of the pandemic from 2019, and then looked at death rates in the US from March to end of April of 2019. So that's kind of the height and the peak period of COVID-19 in the US, and looked at various states. And they found that overall, there were about 570,000 excess deaths that occurred within the 2-month time period from March to April of 2020 compared to 2019. Of that, they estimated that about 65% of those total excess deaths were COVID related. So about 35% or 31,000 excess deaths were attributed to non-COVID related causes. And of that 35%, it's estimated that there was about a 30% spike in heart disease, diabetes, cerebrovascular disease, and Alzheimer's disease deaths just in that 2-month period. And of course, the hardest hit states where COVID-19 was more profound and had the most number of deaths, it experienced and reported more excess deaths. So we know that people are dying as a result of the non-intended consequences of COVID. So whether people are not going to emergency rooms when they have their chest pain and are dying from heart attacks at home, or they're not looking after their diabetes very well and they're getting into hyperglycemia or hypoglycemic episodes and dying from that. But these are the serious unintended consequences from COVID that have dramatic negative repercussions for our population's health. We know that the US has already reported sharp declines in vaccination rates during 2020, and not surprisingly, the hardest hit states reported the most dramatic declines in immunization rates. But you can see that some states like Montana and Pennsylvania, they've reported upwards of 60% reductions in childhood immunization rates during the COVID time period. Other states have reported 40 to 50% declines, and other states just chose not to disclose that information. But we're seeing huge impacts in our immunization rates. Here in Canada, I mentioned earlier that Manitoba reported 25% decline in MMR vaccines and 21% decline in DTaP vaccines in children less than the age of 2. Alberta school-based vaccines, estimated about 50,000 Alberta grade 6 students missed their second dose of HPV and Hep B vaccines, and all of the grade 9 students missed their quadrivalent meningococcal vaccines as well. Other provinces have yet to report their data, but this is a serious and real problem even within Canada. And if we don't catch up with these immunization programs and make sure that these missed doses are caught up with, we're going to be in serious troubles with surgeons in vaccine-preventable diseases. As a result of the decreased immunization rates, we saw early on, even during the lockdowns, public health officials encouraging parents to take their children in for their immunization programs, because these are critical programs and protect our children from other infectious diseases that can spread quite readily within our communities. The Canadian Pediatric Society came out with a statement during the pandemic stating that routine immunizations for children should be kept up to date because any delay or omission in scheduled vaccines put children at risk for common and serious childhood infections. And the WHO said that while the world strives to develop a new vaccine for COVID-19 at record speed, we must not risk losing the fight to protect everyone, everywhere against vaccine-preventable diseases. And these diseases will come roaring back if we do not vaccinate. Of course, there are many reasons for disruption of immunizations, and these this list is not exhaustive and doesn't just apply here locally or provincially or nationally, but also around the world too. So many reasons, including the closure of healthcare facilities or schools. Many medical clinics were closed, or they had reduced services and only provided essential medical care. There is, of course, reallocation or redistribution of healthcare workers' skills, where a lot of our frontline nurses or immunization nurses were then redeployed towards COVID work, including things like contact tracing. There may have been reduced capacity with reduced nursing staff to administer the vaccines. Of course, all of our public health messages of social distancing led, rightfully so, to anxiety or fears of going out, where parents and adults didn't want to take their children out because of the fear of potentially exposing their children to COVID-19. There's also other social determinants of health, including things like people losing their jobs, and that's particularly important for the adult immunization world, where if you lose your job, you don't have the money to pay pay for a vaccine, or you've lost your benefits and you can no longer afford to get a vaccine, or even things like people having to work longer hours and not being able to get in during regular hours to get their immunizations or take their children in to get their vaccines. And other social determinants of health include things like bus services being disrupted. So we see that vulnerable and marginalized populations are being severely impacted, not only in their ability to seek medical services, but even when they want to, they're not able to access medical care or services. There's, of course, lots of misinformation about vaccines. There's travel restrictions, which doesn't really apply here in Canada, but as we saw with the polio campaigns in Africa, for example, there's been huge suspensions and interruptions because of travel restrictions and healthcare workers not being able to go to these villages or towns to then immunize the children within those areas. Currently in Canada, there are no vaccine supply issues, but that may come about. And certainly globally, that is a concern. And a lot of the vaccine supply just wasn't even being distributed to some third world countries because of a lack of flights and because of all the disruptions and interruptions in even trucking services and getting vaccines to the areas that were mostly needed. And of course, there's all the political reasons for disruption of immunizations, and especially now since the United States has pulled out of funding for the WHO, this will severely negatively impact immunization rates globally. But despite all of these reasons, we must not forget that immunizations, especially in infants and toddlers, is an absolute essential service and should absolutely be continued during the pandemic and into the future waves as well. So as a result of the interruptions and lowered immunization uptake rates and the concern about COVID and how to safely administer vaccines during the COVID pandemic, NACI, the National Advisory Committee on Immunizations, issued an interim guidance on continuity of immunization programs because they recognize how important vaccines are. They've been so successful to date, and there's been a lot of work done, and we cannot reverse all of the decades of hard work that we've done and we need to maintain these vaccines during COVID. So NACI came out with an interim guidance, and they say that we should absolutely continue to offer routine immunizations to children, and but if there is insufficient capacity for whatever reason, then routine immunizations and primary series and booster doses should be prioritized for children less than the age of 2, because this is going to be your highest risk population and the most susceptible. Followed that, there are certain precautions that we can certainly take as healthcare providers to protect not only ourselves, but our patients and families as well. So doing things like screening prior to immunization appointments has been an invaluable tool, and most healthcare settings, if not all, implement some kind of a screening program for in-person visits. And we know that these screening programs are highly effective tools and within healthcare settings, and that if somebody screens positive on their COVID screen, well, then of course we would ask them to stay home and not come and seek medical attention or for their immunizations unless absolutely necessary or in an emergency setting. But if it's for a routine appointment, then screening prior to their appointment is a very, very useful tool. Using things like face covering and appropriate PPE procedures for the healthcare provider and for the patients is also another way to eliminate or reduce the risk of COVID transmission. Having better scheduling appointments where we don't have everybody come in together and we space out appointments to longer visits, allowing time, of course, for the healthcare worker to then clean and disinfect surfaces prior to the next appointment. And then, of course, physical distancing as well. So there's many, many precautions that we can take to continue and maintain the immunization programs during the pandemic. NACI also advises that if somebody is symptomatic with any kind of influenza-like symptom, so for example, if somebody is coughing, has a fever or a sore throat, or has a shortness of breath or any kind of a symptom or respiratory symptom, then we should defer all routine immunizations. And especially if somebody is a suspected or probable or confirmed case of COVID, we would ask them to stay home and not go out for routine immunization until their self-isolation period has lapsed. The only exception to that rule is that if post-exposure prophylaxis is required, for example, measles, hepatitis A or B, or rabies, or meningococcal, or varicella post-exposure prophylaxis is required, then we should always give those without delay using appropriate PPE for the healthcare professional. Now, when we talk about PPE, there are certain steps of how to don and doff PPE appropriately. And by following these steps, then the risk then becomes negligible to the healthcare worker. So important steps of how to put on PPE. First step is always to do hand hygiene. So you either wash your hands or use an alcohol-based hand rub. You would then put on a gown if necessary. For the purposes of immunization, I would say that a gown is not necessary if that's all you're going to be doing. But of course, we work in different clinical settings and you might have different other exposures or be doing other procedures in combination with the immunization. So a gown may be necessary. After you put on a gown, you would then put on your procedure or your surgical mask and make sure it's a tight fit around the nose and fits snugly underneath the chin. For most procedures, a surgical mask or procedure mask is sufficient. There's only certain aerosol generating procedures such as intubations, BiPAP, using nebulizers, bronchoscopies that have the potential to generate aerosols. In that case, you would use an N95 mask. But other than that, you would just use a simple procedure mask. And then after that, you would put on your eye protection or your face shield if necessary. And then the last bit is that you would put on your gloves. Now, after you're done with your procedure, if it's an immunization procedure, then there are certain steps that you need to take to take off the PPE appropriately. So the first thing to do is to remove the dirtiest parts of your body that have the most likely potential for contamination. So you would always remove your gloves first, pulling off from the edges and then rolling it inside out and then disposing it in the garbage. You would then do your hand hygiene, either alcohol-based hand rub or washing your hands. You would then take off your gown if you've put one on, roll it inside out, and then put it in the hamper or disposal bin. You would then do hand hygiene, and then you would remove your eye protection or face shield, and then your surgical mask or your procedure mask, and then lastly, you would do your hand hygiene again. And that way, by doing all of these steps in the appropriate order, you would minimize your chances of acquiring COVID to a very negligible risk then. So how to proceed with immunizations according to NACI. So we know that infants and toddlers, we should absolutely prioritize the primary immunization series. So the 2, 4, and 12-month immunizations should be priority, and that should be considered an essential service. Some provinces and territories have suggested that the 18-month immunization can be delayed or postponed, but NACI still says that it's still part of the primary series and should be given if possible. For children, they say that we should prioritize those who have incomplete primary series and that we may defer the 4 to 6 year booster dose if it's necessary, but we have to prioritize it prior to school entry. For school-based programs, of course, essentially all schools were closed early. But once schools reopen, we need to initiate and or complete immunizations once the schools reopen. And if that student was in the midst of a vaccine series, there's no need to restart a series. So for example, if a student had received the hepatitis B vaccine, 1 dose, or the HPV vaccine, and then they come to school, in the fall again, we don't need to restart the series. We just need to continue or complete the series when they come back to school. For adolescents, routine vaccines such as Tdap, HPV, hepatitis B, meningococcal vaccines can be deferred until full healthcare services are available and or when schools reopen. And the reason why we can hold off on these vaccines for adolescents is because the endemic rates of these infections are still quite low. And so even if we just hold off for a period of time until full healthcare resources are open or schools reopen, then that is still okay to do. But we have to make sure that when the schools and healthcare services reopen, that these adolescents are caught up with their vaccines again. Immunizations during pregnancy are absolutely essential, and it's recommended that all pregnant women should receive Tdap at 27 to 32 weeks with every pregnancy, plus influenza come the fall season, and these should continue, and it's preferable to combine these immunizations with another prenatal visit. For our adult population and older adults, we know that this is the group that is particularly susceptible to COVID, and as well as to other infections such as influenza and pneumococcal disease and herpes zoster. But for older, so it's even more vital to protect our adults and older adults with vaccines. And for this group, it's preferable to combine immunizations with another medical visit and offer multiple vaccines if required to minimize the risk of acquiring COVID and also to reduce the number of healthcare encounters that they experience. So we shouldn't be calling in our adults and seniors to only for the sole purpose of getting a vaccine, but we should be offering it and combining it with another healthcare encounter. So for example, if they're coming into the pharmacy to pick up a refill on their medications, we should be offering vaccines at that point. Or if they're coming in for a medical visit for their blood pressure management, we should be giving them the vaccine at that point. Or if they're coming in for their flu vaccine, we should be offering them the herpes zoster as well as the pneumococcal vaccines during their visit as well. Seasonal influenza programs will look very, very different this year because it's unlikely that mass indoor flu clinics that we traditionally had will exist with this upcoming flu season. And currently NACI is exploring alternative delivery strategies, including things like having outdoor flu clinics or having drive-through clinics like they're doing in Australia. But currently NACI is still exploring some other modalities for delivering seasonal flu programs. It's absolutely important to do reminders and recalls if an immunization has been deferred, because we know that if there's been a delay, then the high percentage of individuals who missed a dose of vaccine will not come up and catch up with the vaccine. And not only that, but even if they do come in and catch up with it, it may be sometime later. So it's important to have some kind of a reminder or recall system and to document that there's been a delay or a missed dose of a vaccine as a result of the pandemic. Also important to remember that multi-dose vaccines do not need to be restarted if there has been a delay between doses, and all you simply have to do is complete the series when you're able to. So for example, multi-dose vaccines such as hepatitis A and B vaccines, HPV vaccines, or herpes zoster vaccines, you don't need to restart the series, you just continue it on when you're able to. The exceptions are cholera, traveler's diarrhea, and rabies vaccines for post-exposure prophylaxis, but we shouldn't be seeing any of these because these are really travelers' vaccines. And an important comment about concurrent administration of vaccines is that in general, inactivated vaccines can be administered concurrently with or before or after any other inactivated or live vaccine, but you just have to give it at different sites. So you can give somebody as many vaccines as they need on a same visit as long as you're using different sites. So if somebody has, 2 arms and 2 legs, you could in theory be giving them 4 vaccines in one visit. Live vaccines given parenterally can be administered with other vaccines on the same visit as long as they're at different sites once again. And if 2 live parenteral vaccines are not administered concomitantly, then you have to wait at least 4 weeks before the second one is given. And then for live oral and intranasal vaccines, there's some timing between the cholera inactivated and oral polio live, which need to be spaced 8 hours apart, but we don't use oral poliovirus, the live vaccine in Canada, so that shouldn't be much of an issue here. But just the important principle is that you can give patients inactivated and live vaccines on the same visit. And especially with COVID pandemic, it's preferable to actually give multiple vaccines on the same visit. And also about interchangeability of vaccines. Even though Canada is not experiencing very many vaccine shortages at present, who knows what the situation may be as the pandemic unfolds and as second and third waves of COVID-19 hit. But in general, the same vaccine should be used for all doses in a series if possible. But if there's a manufacturing shortage or if there's any transport or delivery issues and the same vaccine cannot be used from the same manufacturer, then generally all vaccines are interchangeable with another manufacturer. The major exception is going to be your meningococcal B vaccines, which are absolutely not interchangeable because they are completely different vaccines. But for everything else, all of your Tdap, polio, Hib vaccines, meningococcal vaccines, hepatitis A and B, rabies vaccines, rotavirus, typhoid vaccines, those can all be interchangeable with another manufacturers if necessary. So there are undoubtedly going to be many, many public health lessons that are learned at a government and politician level as well. Hopefully, they will learn from the lessons and carry them forward so that we're better prepared as a nation to deal with subsequent waves of COVID. But on an individual level, there are many, many lessons that we can learn. And these include basic principles such as the importance of hand hygiene, avoid touching your face, stay home when sick, disinfecting surfaces, and really taking care of the elderly, the vulnerable, and those with chronic conditions. And the importance, absolute importance and essentialness of vaccines. So for all those who wanted a world with no vaccines, all the naysayers, all the vaccine hesitant individuals, here's the world without one vaccine, and look at the chaos and pandemonium that it has thrown the entire world into. So of course, we as healthcare professionals are important to patients. Patients trust us, they listen to us, they believe in us, and they genuinely believe that we have their best interest at heart. So they will listen to our recommendations. And so very few patients come in asking for things like a pneumococcal or a tetanus or an influenza vaccine. But as soon as we as healthcare professionals make a strong recommendation, then that patient's acceptance of vaccination will dramatically skyrocket. So don't ever downplay your recommendations, and that we should always strongly recommend that patients always get their vaccines. So in summary, vaccine-preventable diseases carry high morbidity and mortality. We know that even brief interruptions in immunization programs will risk outbreaks of VPDs, and continuation of immunization programs during the pandemic is highly recommended and can be done in a safe manner. And let's all do our part as healthcare professionals to keep our patients, families, and communities safe from VPDs. And so we know that the things that are worthwhile take time, and it is not the eyes of the world, but the we's who achieve them. And that is so true of successful and important immunization programs. And with that, I'd be happy to take any questions.
Okay, thank you very much, Dr. Chu, for your very informative presentation covering many topics on maintaining immunization during this pandemic. I'm cognizant of the time, we're going a little bit over, but please note for those who join us later on that this webinar is being recorded. The recording and the slides will be shared with you at a later time and will be available. And we do have a couple questions already being submitted, so if it's okay with you, Dr. Chu, we'll take the question period to 2:15.
Yes, please, yeah.
Okay, for anyone who's not familiar with Zoom, if you have a question, please submit them using the Q&A feature at the bottom of your screen. As a reminder, you can also submit your questions anonymously. All answered questions will appear in your All Questions tab in the Q&A window. So I'm just gonna go ahead and start. There are some similar themes. We have about 8 questions, so I'm just gonna combine them for ease of answering them. We have a question from our participant in the USA, who's also a pharmacist. With the constant information of the misinformation and conspiracy theories that are causing mistrust, how would you suggest combating these issues, and what would you recommend as the most effective forms of media for continued education with providing correct information on the importance of immunization?
Yeah, no, that's a great question. That's certainly a challenge that I think all of us face in the immunization world is the misinformation and all the skeptics and all the controversies and sometimes even just outright lies. And you know, that's a bigger issue at play, not just during the pandemic, but overall with immunization programs. And time and again, when they've looked at ways to deal with vaccine hesitant or just a straight out anti-vaccine individuals, the best way to combat all of those falsities and inaccuracies is really with good scientific information. I mean, we should never stoop down to whatever level the anti-vaccine or vaccine hesitant movement is displaying, and we should never actively engage somebody in, you know, arguments or controversies or whatnot. But one of the approaches that I take is, you know, I'm a physician. My job is to evaluate a credible scientific information and to parse out what's accurate and what's not, and to evaluate all of that. And so I always take the stance that I use, you know, I apply evidence-based medicine to all aspects of my everyday work. And that's exactly what I do with the vaccines as well. So I always just present the data and all the evidence as it is. And I always leave my door open. I'm always sympathetic to whatever concerns. I always listen to patients when they bring in information. And I try to just give them the scientific information to combat whatever concerns they have. But I'm always sympathetic and I leave my doors open. And if patients have further questions about it, then they can always come back and ask me later.
Okay, thank you for that. Another question. What are your thoughts on why there is a 10% variability in the immunization rate for pediatric vaccines? Aren't they usually administered by the pediatrician around the same time? Or is it because the Tdap and the HIP vaccines are 4 doses rather than 3 doses or 1 dose? Or does this have anything to do with cadence or frequency of pediatric visits?
Yeah, so it really depends on the province or territory that one resides in, how vaccines are administered in the childhood programs. So in Alberta, for example, we have public health clinics where public health nurses administer the vaccines. In Ontario, for example, it's done through the family doctor or the pediatrician's office. So it really depends on who's administering it and what's being done within a provincial level. But with the variability within all the different vaccines, it could be the schedule, but we're finding that a lot with vaccine hesitant parents especially, that they're kind of pick and choosing which vaccines they want their child to get based on the flavor of the day. And I don't really know how parents go about with that decision, but we do find that parents will tend to pick and choose, or they're spacing out the intervals that their child is getting vaccinated at. So for example, instead of the traditional 2, 4, 12 period for vaccines, they might choose to do like a 3, 7, 15 type of an interval. And so parents tend to kind of quote unquote customize what their child's vaccine schedule is. And when you start to kind of customize it and shy away from the accepted recommended schedule, that's when there can be errors made. And then that's when you have missed doses or delays in doses. And that could explain the variability as well.
Okay, thank you for that. And the next question is on the other spectrum, other side of the spectrum for older adults. For invasive pneumococcal vaccine 60 years old and older, does the Pneumovax 23 decrease incidence of invasive pneumonia as Prevnar 13?
Yeah, great question. So unfortunately, the data with Pneumovax is not as strong for the prevention of pneumonia. It has the ability to prevent invasive pneumococcal disease, but in terms of prevention of pneumonia, then Prevnar 13 or PCV 13 is the only, is the one that has the strongest evidence for prevention of pneumonia.
Okay, thank you. And another question on misinformation. There seems to be a terrible distrust in reporting of accurate information regarding outbreaks of COVID-19 to agencies such as the CDC, who this is a little bit more on the US end. But how does healthcare providers address this difficult and perhaps politically driven concern in their populations?
Yeah, absolutely. And that's a really, really tough one. And, you know, in Canada, we struggle with it, but even more so in the US, where it is highly politicized or politicalized, I guess. And I think there was just reports yesterday that the White House is now taking over the COVID-19 reporting of cases as from the CDC. And anytime you mix politics with medicine, it gets very, very messy. And I think that's where you're starting to see a lot of discrepancy between what government and the Trump administration is saying about Dr. Fauci, for example, as an infectious disease expert. And so you have the two worlds colliding, the medical and the politics, and that always gets very messy and not fun to deal with. In Canada, here we're more fortunate because they tend to be more divided. But my approach to that sort of thing is, I say that as a physician, this is my medical advice. I don't deal with the politics of it. I don't listen to the politics. My job is to analyze the evidence, analyze the data, and come up with the best recommendation for the patient sitting in front of me.
Okay, thank you for that. The next is a two-part for PPE. What is the appropriate PPE for healthcare workers immunizing in a community setting? And also, are there recommendations? So there's CDC recommendations for glove and eye shield to be used for oral and nasal vaccine due to higher likeliness of contact with mucous membranes. Are there Canadian recommendations for oral nasal vaccines?
So there are no Canadian recommendations specifically for oral or nasal live vaccines, and so nothing in particular about that, but it's just the usual PPE. And so in a community setting, if somebody is administering vaccines within a community setting in isolation, then the PPE that's required would be hand hygiene, put on gloves, and then wearing a facial covering as well. And then same thing for the patient. Now, recognizing that provinces and territories in Canada have different recommendations for what's required for facial coverings or not, but it would make sense that if for a patient to be receiving a vaccine, that they should be wearing some kind of facial covering, just in case, if during the immunization process, they have the sudden urge to cough or sneeze, for example, then at least they're keeping it with a mask on and they're keeping their droplets to themselves and not exposing the healthcare worker at risk. So for all intents and purposes, if you're within a community setting, then gloves and a mask or a face covering is all that's necessary.
Okay, and the next question is regarding fear of fear of parents not taking their children to vaccination. Perhaps it's not about the child contracting COVID-19, but fear of the parents themselves not contracting the disease since adults have more complications. As a healthcare professional, how do we navigate this in encouraging parents to take the risk and go for their child's routine immunization?
Yeah, so we know that, parents are going to be across all ages, whether you have young parents or older parents, and there's always going to be the risk of COVID. But we know that even amongst the population that's less than the age of 60, that the chances of getting a severe outcome from COVID, including death, is very low. So, there's going to be an increment gradation of your risk of dying from COVID, and the older you are, the more risk you are. But I would say that for most parents, even between the ages of 20 to 50, the risk of getting COVID and ending up in ICU or being hospitalized is very low. And not only that, but if they don't bring their child in, then the risk of their child getting a vaccine-preventable disease or an infection is actually higher than getting COVID. And the consequences can be much more severe than with COVID. So for example, if you don't bring that child in to get their meningitis vaccine, that child gets meningitis and dies from it, that's going to be more of a severe outcome. Or if that child doesn't get their pneumococcal vaccine, and children tend to be carriers of strep pneumo, they then pass it on to parents. Well, even adults, any adult over the age of 18 is at high risk of getting pneumonia and getting pneumococcal disease as well. So there's going to be, we always have to weigh balance risk versus benefits, and we always have to balance that. But in this case, the fear of COVID, we shouldn't replace one healthcare crisis with another, and that there's still going to be the ongoing and very, very severe and real risk of getting other infections that aren't COVID related if parents abstain from vaccines for their children.
Okay, and the next question is about school immunization. Due to the disruption of the grade 7 age immunization, HPV and Hep B, would the students still be eligible to receive the immunizations public funded once they start high school?
Yeah, great question. And that's going to depend on the province or territory that student resides in. But NACI's recommendation is that if there's been an interruption in school-based programs, that child or student should continue to be eligible for the vaccine completion of the series.
Okay. Next questions on healthcare providers. So some of our healthcare providers refuse to immunize either all of their clients or only certain populations. Do you have any advice as to what public health can do to convince these practitioners, or are they allowed to deny services to clients when they have access to ordering public funded vaccines?
Yeah, again, that becomes a very dicey topic, and really it depends on the provincial jurisdiction or the territorial jurisdiction that they work in and what the medical college recommendation is. I can say that in Alberta, our physician college says that we are, as physicians, liable to administer and deliver whatever treatment is accepted according to the standard of care. So whatever standard of care is accepted by the medical community that you work in is the standard that we should be delivering to our patients. And that's what our Canadian Protective Medical Association also says as well for medical legal liability. So, you know, everybody has practice variations, what they're comfortable with doing and what their beliefs are. And, you know, no practitioner should be forced to do something that they don't want to do. But you also, as a physician, morally and also, you know, medically, you have a responsibility to then offer or be able to offer your patient an area where they can seek additional resources. So if that practitioner is not comfortable delivering vaccines, well, then they should be able to offer additional resources or direct the patient elsewhere that they can seek these services that they require.
Okay, so we're about 2:15. We have 2 questions left. We're going to finish those, and that'll conclude our webinar. So thank you, though, for those who are staying with us. What is your recommendation for vaccinations in patients with compromised immune system?
Yeah, so in that NACI interim statement, they did leave a section there that's specifically for immunocompromised. And of course, we know that immunocompromised is going to be at higher risk of getting serious outcomes, including death, as a result of not getting their immunizations. So what NACI is recommending in that statement is that, of course, immunocompromised should receive their vaccines, but to do it in a different setting. So for example, some clinics may offer drive-through immunization programs available for their immunocompromised patients, or having alternative settings, and of course combining the immunization of immunocompromised patient with another medical visit, and perhaps even having, so for example, if somebody has cancer and they're going to the cancer center for their appointment, that perhaps these cancer centers will now carry vaccines and be able to administer it on the day of their medical appointment as well. So having additional additional clinics offer vaccines for this population would be helpful.
Okay, and this is our last question. Are pharmacies in Canada offering pneumococcal vaccines for older adults along with influenza or shingles vaccine?
Yes. Sorry, can you repeat that again?
Are pharmacies in Canada offering pneumococcus vaccine for older adults along with influenza and shingles
Yes.
vaccine?
Oh, yes, they are. Yeah. So pharmacists in Alberta, depending on the province or area that they practice in, some may even be able to prescribe. For example, in Alberta, our pharmacists are able to prescribe vaccines as well. And in some provinces, they're able to administer them. So certainly herpes zoster and pneumococcal and influenza vaccines, pharmacists are playing a huge role in being able to administer and in some cases even prescribe these vaccines.
Okay, thank you very much, Dr. Chu, for answering those questions for us. If there are any other questions that we didn't get to, we'll get in contact with Dr. Chu and be able to provide you with answers. So thank you everyone for attending our webinar today, and thank you, Dr. Chu, for your wonderful and informative presentation. As a quick reminder, please don't forget to fill out the survey upon the closing of this webinar. We look forward to your feedbacks so that we can make improvements based on your suggestions. Thank you to everyone, and have a good afternoon and stay safe.
Thank you very much.